Welcome to another OU Medicine Live Chat. I'm Teresa Green. So glad you're with us. Great topic today, breakthroughs in pediatric anesthesia. That's our topic. We have a wonderful guest joining us, Dr. Michelle Sheff, and we so appreciate you for being here. You are director, correct?
That's right.
Of pediatric cardiovascular anesthesia.
That's correct.
At the Children's Heart Center here at the Children's Hospital at OU Medical Center. That's a big, long title. But I think it's really important to talk about because you played an integral role in getting this heart center up and running. Talk to me about what makes the heart center so important to a center like ours.
I think this is a great opportunity for families in Oklahoma, for the children with congenital heart disease, so they have a place that they can go to. They don't have to leave home. They can have a center of excellence right here where the surgeries can be performed and great experts exist at home to take care of those children. And cardiovascular anesthesia is just one part of it. It's an entire team, surgeons, cardiologists, interventional, ICU doctors. I'm just one part of a team that's going to take care of these kids.
You know, statistically, I guess in my mind, I thought congenital heart defects would be exceedingly rare, but it's 1 in 100.
That's
I know
correct.
Not all of them need surgery, but that's much more common than I would have anticipated. What types of anomalies might we see that would require surgery?
From newborn surgery such as PDAs or patent ductus arteriosus to the very complex kind where they're just born with one pumping chamber and that they need surgery within the first few days of life. There are certain conditions where if we don't do an intervention in the first week, they don't have a chance to survive, and so it's a great time for us in Oklahoma that we can do these surgeries at home.
This specialty, I mean, everyone hears about anesthesia, and I guess we just kind of take it for granted as part of the surgery, but to me, in my mind, that's one of the most important aspects of surgery because your specialty is the one that's responsible for making sure when I'm in surgery I'm still breathing, my heart's still beating, and controlling pain too, correct?
That's correct.
Pediatric anesthesia, we're talking about breakthroughs. Can we talk a little bit about where we were with this specialty and where we've come?
We've come a long way in the last 100 years in terms of advances in pediatric anesthesia, and especially in cardiac anesthesia in the last 40 years. You know, we have technology that allows us to see 3D echoes and, you know, advanced placement of intravenous catheters with ultrasound, you know, that can limit the number of sticks that babies have to endure to actually get the lines in that we need to do surgeries with. We have very new medications that allow us to take breathing tubes out quicker so that they can wake up earlier in the intensive care unit or the recovery room, and they don't need to stay in the intensive care unit for days after a surgery. You know, we have monitors that can measure oxygen saturation in the brain so that we can watch the brain carefully and make sure that these babies wake up with the same neurodevelopmental outcome that they went into surgery with. So
that's exciting. Jay asked the question I was going to ask, so I'm going to let him ask it. Is anesthesia different for infants and children than for adults? If so, how is it different?
Jay, thank you for that question. Yes, it's very different. They are not adults. They are much smaller. Their organs are a little bit immaturely developed compared to an adult. And we have to be very careful with our dosages of medication as well as the amount of intravenous fluids and things that we apply. Dosages can be very dangerous in children, and pediatric anesthesiologists are very aware of that.
Madeline is wondering, if my child was born with a heart defect that will require surgery, what specific question should I ask the anesthesiologist?
Madeline, I would ask my anesthesiologist exactly what plans would he have for my baby having this surgery, how long do you think the breathing tube would stay in, and what kind of medication would be required to keep my baby comfortable, and what kind of monitoring and what kind of intravenous lines would be needed to help keep my baby safe for the surgery.
You know, one of the things that crosses my mind when you think about your baby having surgery, especially, I mean, I would say even with my first child, I was even more paranoid about the baby being away from me. How soon can you and baby be reunited after surgery, after coming out of anesthesia?
Well, for pediatric anesthesia cases, we often bring parents back to the operating room as the baby's falling asleep. It's very comfortable, the babies are less anxious, and often when they wake up in the recovery room, as soon as the vitals are stable, we bring a parent in. Cardiac surgery is not that way. We often have them give their hugs and kisses in the preoperative area so I can really focus on that baby in the operating room. And often before going to the ICU, we like to stop and let parents have a glance at baby before we go to the intensive care unit.
For children born with certain anomalies of the heart, there are some aspects of their overall health that can impact what you do as well, correct?
That's right.
They may not have the same the same amount of oxygen in their bloodstream, for instance,
Yes.
that other babies might have. Can you talk a little bit about how you deal with those challenges and maybe why that happens?
Absolutely. Babies with congenital heart disease, sometimes they're not born with normal connections to their lungs and to the rest of their body. And sometimes we have to make connections in the operating room to give them more blood supply to their body and actually give them less supply to their lungs so that they do stay a little blue. And so it's kind of important that anesthesiologists know that, because oxygen can be dangerous to a baby with congenital heart disease. Giving extra oxygen can be dangerous to a child with congenital heart disease, and there's a careful balance between the two. And that's why I think cardiac anesthesiologists are the best ones to care for those children.
Well, you led me right into a question from Chelsea that I may expand on, but Chelsea maybe is looking at going into medicine. She wants to know, what does it take to specialize in pediatric cardiovascular anesthesia?
Well, you have to be an anesthesiologist first, which actually requires college, med school, and anesthesia residency, which is 4 years. And then there's a fellowship in pediatric anesthesia where you do a complete year of specialized training in pediatric anesthesia. And in that year, you may do anywhere between 2 to 4 months of cardiac anesthesia, depending on the institution that you choose. And then in addition to that, you can choose a hospital that will provide you either 6 months or a year of further training exclusive in cardiac anesthesia.
I'm just doing the math. So we're starting with initially 12 years.
Yes.
And then did you say 6 months after the 12 years?
12 plus 1 is 13, plus 6 are a year.
Okay, 13 and a half years.
Mm-hmm.
Wow. That's a lot of training.
It is.
But it's one of those specialties that you probably, to make sure you have all the know-how and all the experience, because I personally think little ones in surgery, particularly these newborns, those would be the most challenging for me emotionally.
They are. And yet they're the most rewarding as well.
What makes it so rewarding to be in
You
this
know,
specialty?
it's wonderful for me to see a baby that I can give hope and a chance for a full and complete life, whereas before there was no chance. And to give that hope to a family and to know that I had a part to play in it is just the most satisfying thing for me.
And we have a question that was from Jan, and it's something I asked a little bit earlier, but maybe we can expand on it some. How has anesthesia for infants changed over the years? Are there new methods or technologies that make it better, safer? You talked about a few things, the echo, things that you're able to monitor. When have these all come online? Or is this the last 10 years, last 20 years?
I would say the last 40 years we've had a dramatic improvement in our monitoring capability for pediatric anesthesia. And I think the biggest improvement was the development of the pulse oximeter that measures the oxygen saturation. I am not sure how my predecessors just did the anesthesia without it, but I just could not do anesthesia without all these monitors giving me all of this ancillary support, knowing that I'm taking very good care of these kids, and knowing that these numbers all mean that these kids are safe under the drapes in my care.
When we look at our surgical team, and you've talked about the team, and we have a fabulous heart surgeon here now, Dr. Burkhardt, who
Absolutely.
is able to work with these tiny little babies and give them that shot at life that they might not otherwise have right here at home without having to travel thousands of miles away. But it really is a team. I mean, it's not just the surgeon. It requires a lot of specialization in that operating room, correct?
Absolutely, and it's I would even go as far back as the housekeeper that cleans the OR so that the children don't get infections, to the respiratory therapist that brings a ventilator into the operating room, to the scrub techs and to the nurses and to the perfusion staff. A cardiac team is the ultimate in outcomes. It's a proven fact that the more cohesive a team is, the better the outcome and the more efficient the system that's created by it. And I firsthand have experienced that here. I have been here 6 months, and initially I was the new team member, and initially we had many, many conversations as I was being integrated into this team, and now I see that the conversation is virtually nonverbal. We understand each other so well. We know each other's roles in the operating room, and the outcomes have just been absolutely incredible, and that is just a testament to what a great team we have in the operating room.
A question just submitted. Do some hospitals just use a general anesthesiologist for children's surgeries?
For general pediatric surgeries, sometimes they do use a general anesthesiologist, but at Oklahoma Children's, every single pediatric anesthesiologist is fellowship trained in pediatric anesthesia.
There are so many unique aspects to, I think, and we say it, children are not just little adults.
That's correct.
And that goes from their blood vessels being smaller to their organs being smaller, although sometimes with the heart it may be larger than it's supposed to be. There are all kinds of nuances, I would imagine, that make working with pediatric patients very different. Can you talk about some of those?
Yes, I think they are challenging. I find adults a little challenging, to be honest with you. It's just what's comfortable and what feels right, and I just feel very comfortable with kids. And it's something that you're either good at or you're not, and it kind of finds you.
I was going to ask that. How did it find you? How did you know, as you go through medical school, you get into the residency, how did you know it was going to be pediatrics?
I always loved children. I knew that I wanted to do something with children, and the opportunity to do anesthesia and be in the operating room and have to work with children was exciting. I just had an opportunity to start a heart program in another state, and it was just a fabulous opportunity, and I loved it, so I knew exactly what I needed to do here.
Did you, I mean, because you're even more specialized than just pediatric anesthesia. You specialize in pediatric cardiovascular anesthesia. You're working with the heart surgeon. Are there additional things you needed to learn and study to be able to be that specialized? It's almost like a micro specialty.
Well, you just do a lot of cases with your surgeon, and you do the additional 6 months in a heart center.
Have a question from JJ. My son is going to have surgery that will require anesthesia. All of my friends are warning me that he will be virtually inconsolable as he is coming out from under the anesthesia. Is this true? I'm sure they're just trying to prepare me, but it makes me nervous. That's from JJ.
All right, thanks JJ for that question. Is there an age for the child?
They didn't list
They
the
didn't
age,
say.
so I'm assuming probably
Baby?
younger.
Baby? Babies usually, when they come out of anesthesia, they are inconsolable at times. It can be related to a couple of factors. Number one, the anesthetic agent that we use sometimes makes small babies disoriented, and it's a time-limited factor, and babies will kind of breathe that anesthesia gas out, and then they will settle. Often they are disoriented because they're in new hands in the recovery room and they don't see their parents' faces and everything's unfamiliar, and I would advise just asking to be brought into the recovery room, and you can be that consoling factor for your baby.
And don't panic.
Absolutely.
That's part of the normal process.
Absolutely. Baby's safe. If baby's crying, baby's breathing, the heart rate's good, and baby's safe, and we'll settle.
Okay. Can you talk a little bit about how anesthesia is given to babies? Because I don't think everyone
Absolutely.
really understands the process.
Absolutely. Uh, we can give it two ways. If a baby has an intravenous catheter in place, sometimes we can give medicine through an IV, but about 90% of time they come to the operating room without an IV. And if that's the case, we actually give it through a mask that we hold to baby's face, and it delivers an anesthetic gas. And then baby breathes in and out, and that fills the lungs, and the lungs fill the vessels with the anesthetic gas that goes to the lungs and then goes in the blood and then goes to the brain, and the baby falls asleep.
Are there different medications used in these very small pediatric patients than are used in, say, an adult population?
Absolutely. We use different medications for children. Definitely the dosage. Everything is weight-based for pediatric anesthesia. We calculate everything based on their weights. And in cardiac babies, we tend to use a higher narcotic or pain technique and less of the other intravenous sedatives that may drop blood pressure and may be unsafe for a cardiac baby.
And I was just thinking about that with a cardiac baby, because you've got some limitations to the heart already. I'm assuming that you have to factor that in as well, not just weight. You've got to figure out how well is that heart functioning.
Absolutely. Sometimes we have to actually go to sleep very, very slowly and very carefully because sometimes they don't tolerate the gas very well at all. And it can be a very strenuous and stressful time, and I'm really focused, very, very focused during the induction period and when these babies go to sleep.
During the surgery, for parents who don't know, you've got the surgeon working, the anesthesiologist is there, and you're monitoring baby too.
Absolutely.
Talk to me about what that monitoring process entails.
We're actually standing next to each other during the entire case. I'm at the head of the drapes, and he is right next to me operating, and I'm watching what he's doing, and he's looking at me, and I'm watching the monitor the entire time. And we are communicating at every level until the baby is in the intensive care unit.
How, I mean, this sounds so simplistic, but I know these surgeries can be extremely complicated. How long can a baby remain under anesthesia? Do we have a clock ticking? Do we know that, okay, because I know some of the procedures can be quite long. Do we have a limit to how long we can keep baby under?
No, we will keep baby under anesthesia as long as it's required for the surgery to be complete. The surgeon's very aware of how long the child is on the bypass machine, and that's critical.
Okay,
And so
don't panic, because that's one of the things.
Absolutely.
We've had the ability to videotape some surgeries, and I know sometimes they can be very long surgeries because this is very delicate work.
Absolutely.
So don't panic.
Absolutely.
If the surgery is going longer. Is family updated?
Every hour, the nurse calls out to the family and updates the family as to the progress of the case. And as soon as the lines are put in and baby's positioned, they receive a call. And as I said, on the way up to the intensive care unit, I like to stop so they can get a kiss on the way up.
How do you best prepare mom and dad for what you will do in the surgery and then for the surgery overall? What kinds of things do you talk to them about?
Well, it's an overwhelming time for them. It's usually, especially newborns, because they've barely had time to get to know their baby, and now they have to have this huge surgery. And so it's a very overwhelming time. I do explain everything that's going to happen to baby, but I really emphasize that I want them to just give the baby lots of hugs and kisses and to trust us. And we will take the best care of their baby and treat their baby as if they were our own. And with that said, just leave it to me, and leave it to Dr. Burkhart, and leave it to the cardiac team, and we will take care of your baby.
So when that baby's handed over to you, that's your baby.
Absolutely, that's my baby. And I teach residents, that are training under anesthesia, and I tell them, we get 5 minutes as an anesthesiologist, and we take away the most precious gift a parent has is that child, and with the promise that you're going to give that child back in the same condition, and it's a huge responsibility. And I tell my residents that you please remember this when you go out into practice, that you are taking somebody's most precious gift, and you have a responsibility.
One of the things that I think is unique about our center is just what you said. You're working with the next generation, those people who will follow in your footsteps. What does it take, number one, to know this is the right specialty for you, and number two, to be very good at what you do?
For pediatric cardiac anesthesia, I think it has to find you. It's a passion, because it can be very frustrating at times and overwhelming, and if you can't find it within yourself to keep going and to push harder and to excel, you can easily become frustrated and say, I can't do this. And so I encourage, physicians to come and follow me and see what I do and see if it's a good fit. You have to really, really be vigilant, and you have to, it's all in the details. It's extremely detail oriented if you're going to do cardiac anesthesia. Everything matters, from where you tape something to where you put something to exactly where the drips are. Everything is important. And if you can develop that philosophy and be that vigilant and have that endurance, then you could be a good cardiac anesthesiologist.
Do you enjoy working with the residents? Do you enjoy that aspect of what you do as well, the fact that you are teaching and training?
I do enjoy it. I think that if I can find one or two that would love to do what I do, then I think I've accomplished something, because I can't do this forever, and I know that there's going to be babies that are going to have this, and Oklahoma will need future cardiac anesthesiologists. Right now, I'm the only one, and we need to build a team of cardiac anesthesiologists, and so I need to see who will come and join me.
That puts a lot of pressure on your shoulders because you are the only one, and I know with Dr. Burkhart, he is the one who's capable of doing these very complicated surgeries. So the two of you together are this amazing team, which I'm not just trying to blow smoke, but when you think about that, there's a magic that happens when you have the right people in the OR, correct?
Absolutely. Absolutely. A lot of cardiac programs fail because of poor surgeon, poor anesthesia, or poor infrastructure. We have everything. We are on a trajectory to be a top-tier cardiac program. There is nothing that can stop us now.
That's very exciting.
It's an exciting time. I can't be happier.
As we're talking and as we've been talking about what parents need to know about anesthesia, are there any aspects of this that we've not covered? Any things that you would really want mom and dad to understand, and even people who are expecting baby? Because sometimes, and I hate to say, it's like you want to think about everything going right, but I think sometimes as a mom expecting a baby, we also need to be prepared. If we're talking 1 in 100 babies, should my baby be that 1 in 100? What should I know? Not that I'm trying to panic you, but just what should I know going into this?
I want parents to know, number one, that there's hope. Because sometimes when you get a diagnosis that your child has congenital heart disease, it can be devastating. And I want them to know that, there's hope, and we have an excellent heart center, and we have excellent experts in the field who are going to discuss their baby's case in a collaborative, environment. We discuss babies' cases every week, and there's strength in numbers, and every expert, whether it's anesthesia or perfusion or surgery or cardiology, we all put in our opinions, and we decide the best option for that baby. And then after we do the intervention, there's very close follow-up afterwards. I want parents to know that there is an excellent center of excellence here in Oklahoma, and that we will definitely take the very best care of their child, treat them just as if they were our own, and we will love them.
And that's the most important aspect, is knowing that you've got this team, and I am truly amazed. I don't think people understand the thought and the effort that goes together. You talked about coming together as a team, and those team meetings where, I know I compare it to sports sometimes, you know what you're up against,
Mm-hmm.
and you're going to have a game plan. And every member of that team has a voice.
Absolutely. I have a son who's a left-footed striker, and he's a little arrogant, and he comes home and he says, well, I won the game, and I often have to tell him, son, there's no I in team, and alone you will never score goals and you will never win games. And this is it. I am just a cardiac anesthesiologist, but as part of the heart team, I'm doing great things.
So you've talked about building this program, and where we are. Where are we also going with it? What is the dream?
The dream is to be a top-tier cardiac program on the U.S. News and World Report.
That's awesome.
And we won't stop till we get there, until we save every baby in Oklahoma that has congenital heart disease and allow them to lead a full and complete life.
Well, it's exciting to be able to share your story with our audience today. We want to thank you for joining us. A great specialty. I don't know that I could do what you do. In fact, I'm sure that I could not do what you do, but I am so glad that we have people like you who are there to take care of these tiny, tiny patients of ours.
Well, thank you for having me. It's been
Michelle,
a pleasure.
Michelle Sheth, Dr. Michelle Sheth, thank you so much. She is with the Children's Heart Center at the Children's Hospital at OU Medical Center, and we are thrilled to have the team with us. Again, thank you for being with us. Thank you, and do join us next time for the next OU Medicine Live Chat. Have a great day.